Okay, students, this is the last chapter I didn't finish this morning in lecture, so we are going to be identifying the needs, identify infants in need of resuscitation. Okay, so you can anticipate a baby that might need resuscitation and have equipment and personnel available to be in the delivery room to receive the baby. However, keep in mind that in every delivery, there's always one person at every delivery who is qualified in neonatal resuscitation. So that could be a labor nurse, the charge nurse, and then if you're anticipating a baby would definitely require resuscitation, then you would probably alert the NICU nurses to be there for your delivery. But anyways, so in labor, if you have a baby with non-reassuring fetal heart rate patterns, you may think that you might be having a resuscitation. However, we do deal with non-reassuring fetal heart rate patterns quite often during labor, and then when baby's born, baby is absolutely fine. So if you think about it, in labor, if a baby's having bad heart rates, that could be attributed to a uteral placental insufficiency or cord compression that is causing your bad heart rates. So those babies are having some sort of problem getting oxygen. So if you think about it, when babies are born and able to breathe oxygen on their own, typically they do just fine and need absolutely no resuscitation. However, that is in no way saying that you can think, well, if I have non-reassuring heart rate patterns in labor and my baby's born and breathing oxygen, I won't need help, or baby won't need help, so I don't need to plan. No, that's not saying that. You always plan for the worst case scenario, and then when you don't need that help, then that's fine, but at least they're there in case you do. So a sustained bradycardia, however, might be a little more significant than just some non-reassuring fetal heart rate patterns. A sustained bradycardia, baby is having a sustained hypoxia, therefore you may anticipate that this baby may have some hypoxemia at delivery and therefore would definitely probably need some resuscitation. So difficult labor, difficult birth would be reasons that you might need resuscitation at delivery. And then if you have fetal scalp pHs of less than 2.0, then that is definitely telling you that you've got a baby that is suffering from acidosis. So we do have a problem with baby. However, we don't typically routinely do scalp pHs. As a matter of fact, like I have never really done one in my practice at all. So they don't really change. If we're concerned about our baby, then it doesn't really change what we're going to do. We're going to plan to have people there. A fetal scalp pH would be just like confirming what you already anticipate, and the risk of doing that might outweigh the benefit of finding out what your pH is. Okay, we will still be dealing with baby at delivery, so maybe the risks of doing a fetal scalp pH are not worth it. Definitely, if your baby has meconium in the amniotic fluid, you absolutely are going to have a NICU team there. Remember, if your baby has meconium, you're going to have the team there, so if baby is born not crying, not breathing, and limp, you're going to go straight to the warmer. You're going to intubate to visualize cords and suction at the cords, the vocal cords, okay? If there's significant bleeding, then you can assume that your baby may be anemic and will need support. Premature or small for gestational age, well, especially premature babies that you're anticipating do not have surfactant production, will need assistance with their respirations, okay? If you have unexpected anomalies, Oligopolyhydramnios. So if you have those conditions, then you may have a baby who is already compromised and would need support. Narcotic use in labor, especially narcotic use within 2 hours of delivery, then we're going to anticipate that baby has received that narcotic and is also sedated, so would not really want to breathe well, so would need stimulation and support until that narcotic has wore off. An infant of a diabetic mother, so we don't typically have a resuscitation team just because our mother is diabetic. If our mother had a very uncontrolled diabetes, yeah, then maybe so. And of course, anemia. So what happens when we have a baby who has been asphyxiated? Okay, so as far as circulatory changes, baby will have a difficulty transitioning from fetal circulation to extrauterine circulation. Extrauterine circulation is the circulation that you and I have today. It's what we want baby to develop or quickly transition to after birth. If they don't quickly transition to it, then they stay in this persistent fetal circulation, which, if you remember from the earlier recording, persistent fetal circulation, so we're not getting that big blood supply to the lung to now pick up oxygen and deliver to the rest of the body. So this is going to be a severe problem for baby, okay? Respiratory changes, so if we have a baby who's asphyxiated, so this baby is going to come out and really not want to breathe well. We're going to still have poor lung expansion, which is going to continue to, we're not going to be increasing our PO2, so therefore our pulmonary pressures are not going to decrease. We're going to still have that increased pulmonary vascular resistance, which is also going to keep us in our persistent fetal circulation. This is all just a vicious cycle, okay? Biochemical changes, so we have hypoxemia, that means decreased oxygen in the blood, and therefore decreased oxygen to the tissues. Hypercarbia, so our PO2 is staying low, our PCO2 is staying high. And because we don't have oxygen, we're in an anaerobic metabolism, which is going to increase our metabolic acidosis, which will then, this is a continually compounding problem, and now we have brain damage and then death. So we will be, of course, intervening before that. So at time of birth, how do we know when the baby is born whether or not we need to resuscitate? So first of all, everybody's focused on these APGAR scores, which are a really cool assessment, an assessment thing to do. However, the APGAR score does not tell us whether or not we need to resuscitate. So the first APGAR score is done at 1 minute of age. So you are not going to wait 60 seconds before you decide whether or not to intervene for a baby. So you ask yourself these questions, or you ask these questions of the baby. Is the baby full term? Yes or no? Is the baby breathing or crying at birth? Yes or no? Does the baby have good muscle tone? Yes or no? So if you answer no to any one of these questions, you probably are going to perform some level of resuscitation. Now, that level of resuscitation may simply be drying and trying to really stimulate this baby to start crying, okay? And as babies start to cry, they create those pressures in the lungs, which helps push the fluid out, and then it also opens those lungs up to receive the oxygen. The oxygen then can be circulated, and then we would increase and have good muscle tone. If we don't have good muscle tone, we're flaccid, we're probably not oxygenating. Okay, if we're not breathing and crying, we're probably not oxygenating. If we're not full term, we're preterm, then we're probably having a problem oxygenating or breathing. Okay, so those are questions that you want to ask. Now, the first thing that we do to resuscitate a baby is to dry baby with a warm towels And during that drying, we're stimulating the baby. So that's a kind of like a dual process there, with two different outcome, with an outcome that we're causing this baby to start crying, okay? And we're keeping this baby warm, we're drying this baby off. Now, if usually we go straight to mom's chest with the baby, but let's just say we're going straight to the warmer. So when you put the baby on the warmer, you're drying and stimulating, and then you position the baby on the baby's back with the head slightly extended. If you need to, you suction the mouth and the nose. And then you evaluate respiratory effort, heart rate, color, pulse, and oximetry. And we do that in a sequence, okay? So let me go back, sorry. So we evaluate respirations. We're looking for chest rise. We're possibly even listening with a stethoscope to respirations. So we evaluate respirations for 30 seconds, and then we evaluate heart rate, okay? We don't put our stethoscope on the chest first thing and listen to a heart rate and hear that maybe we have a low heart rate, and then we jump into this huge resuscitation. We evaluate and take care of the respirations first. We have 30 seconds, okay? So if we ended up needing to intervene for baby with their respiratory efforts, so they weren't crying, they weren't having consistent respirations, maybe they weren't breathing at all, or maybe they were just gasping, then we would provide positive pressure ventilation. That's with a bag and mask over the baby's face, and we would be compressing the bag at our rescue for rescue breathing. We would do that for 30 seconds. Then we would evaluate our heart rate. If our heart rate was greater than 100 beats a minute and we were breathing adequately, we would start weaning the oxygen off the baby. We wouldn't just abruptly stop providing oxygen. We would just slowly wean it off. However, if our respirations were greater than 100 and we did not have adequate respiratory effort, we would continue with the positive pressure ventilation, okay? If our heart rate was 60 to 100 beats a minute, we are definitely providing positive pressure ventilation. The theory is if you oxygenate the baby, you will increase the heart rate, okay? So we provide positive pressure ventilation. The other scenario is if our heart rate is less than 60 beats a minute. If it's less than 60 beats a minute, we provide positive pressure ventilation and chest compressions, okay? If we have provided chest compressions, we do that for about 45 seconds, and then we reevaluate our heart rate. If our heart rate is in these parameters as we went through before, we continue those interventions, okay? So if our initial heart rate was, say, 40 beats per minute, we would be doing positive pressure ventilation and chest compressions for about 45 seconds. Then we would reevaluate our heart rate. If it was above 60, say for instance, if it was 80, then we would stop doing chest compressions, but we would still be providing positive pressure ventilation, okay? So that's how that works until we get heart rates and respiratory rates that are normal. Now, with every delivery, our equipment is always stocked and ready to go in every labor room for every delivery. But right before delivery, we will want to go in and just check all of our equipment, make sure everything's plugged in, make sure everything's working properly, making sure our bag mask is working properly, that it doesn't have any leaks, that our pressures are appropriate. We start pre-warming the warmer so that when we put the baby over there, it's not a cold surface for the baby. And like I said before, there is a staff person at every delivery who is trained in neonatal resuscitation. So we placed the baby on the warmer, we've dried and stimulated, we've slightly positioned the head in the sniffing position. We evaluate the respiratory rate or the respirations. If baby is not breathing or gasping, then we provide 30 seconds of positive pressure ventilation. During that time that we are providing positive pressure ventilation, someone is putting a pulse oximetry on the right upper extremity. Okay, so now we also have our positive pressure ventilation, and we have an oxygen saturation reading. And then after 30 seconds, we evaluate our heart rate, as I said before, and there are our parameters again. Okay. Now, if we are continuing to do resuscitation, positive pressure ventilations, and chest compressions, then we are going to intubate and provide respiratory support through intubation, and then we will also be placing an OG tube. We place the OG tube to keep the stomach decompressed. If we're continuing to provide respiratory support through intubation and or chest compressions, then we are going to consider putting in an umbilical vein catheter or a UVC, so that we can start giving meds, which would be epinephrine or fluid support, and this baby would be transferred to the NICU, and you can transfer care to those nurses. So here is just a picture of how the baby is positioned on their back. You can see that the head is just slightly extended in like a sniffing position, and this is the appropriate way to hold the bag mask, except for the bag is actually on the wrong side according to how the nurse would be holding it. Okay, so she needs that left hand there. That hand would actually be squeezing the bag, okay? Or she needs to switch hands, one or the other. And here is a picture of we're doing positive pressure ventilation. So one nurse is providing positive pressure ventilation. The other nurse is providing chest compressions. The preferred method to give baby chest compressions is the 2-thumb method. Then you also have the choice of doing the 2-finger method as well, but the preferred method is the 2-finger method. Okay. All right. So now we're going to talk about respiratory distress for baby and the different ways that it will present. So the first one is respiratory distress syndrome. You can change syndrome to surfactant. If your baby has respiratory distress syndrome, then they do have a surfactant problem. So this does occur in premature infants or infants who have some sort of surfactant deficiency disease. But more often than not, it's going to be because of prematurity. Okay. Remember, surfactant covers the alveoli and helps keep those alveoli opened at the end of expiration. Before birth, we can anticipate a baby to have respiratory distress syndrome because of being premature. So if we have them in preterm labor, then we will try to administer glucocorticoids to mother, and it's a 2-dose regimen, so she will get the steroid, and then 24 hours later she will get the second dose of steroid. Okay, betamethasone is the drug that we use. After birth, if the baby still is having problems with surfactant, then we can give surfactant, and these babies will be in the NICU receiving that. And so they'll be monitoring blood gases, continuous pulse oximetry, and watching for continued or worsening signs of respiratory distress. Now, these babies may need some sort of ventilatory support. And then if they do, while we're doing the serial blood gases, if we are seeing an acid-based problem like a metabolic acidosis or a respiratory acidosis, we will be doing what we can to correct that. We will be maintaining temperature, so they'll be on a servo warmer. So in other words, the warmer, we will attach a probe to baby that feeds into the warmer that continually tracks baby's temperature and that regulates the heat output according to the baby's temperature to keep the baby normothermic. We will be providing nutrition as soon as we get the respiratory status stable. So if you have a baby that's having respiratory issues, you do not want to fill their belly with food. Okay, we want to keep their belly decompressed so that it's easier for them to breathe, and then once we get baby's respiratory status stable, then we can start providing nutrition. And then of course we're going to do what we need to do to protect the baby from infection. So depending on how preterm this baby is, how susceptible they are to infection, this baby may be in protective isolation, like in an incubator, to protect this baby from exposure. Okay. Now, the other type of respiratory problems babies may have is what's called transient tachypnea of the newborn. So, in the name of this is transient. So this is a temporary problem for baby. They are tachypnic, and it happens to the newborn usually at term. We see this a lot with C-section babies that are having problem processing their fluid in their lungs because they were born by C-section. So that's the deal. They have babies with transient tachypnea of the newborn have a problem clearing the fluid from their lungs. So they have a period in which they're tachypnic, they're breathing faster because they still have fluid in their lungs, so they're having a hard time getting oxygen, so they're breathing faster to try to bring in more oxygen. So when babies are breathing faster, we also see other signs of respiratory effort. Okay, so increased work of breathing. So those symptoms will be expiratory grunting. Grunting is a sound that babies make. When parents hear this sound for the first time, they think, oh, how sweet, my baby is singing. And I don't know how this is going to sound on this recording, but it just sounds like this. So that sounds very sweet, but that's not very sweet. That's called expiratory grunting. Babies are trying to create pressure in their airway to forcefully blow out their gases so that they can take in oxygen. Nasal flaring. So babies are nose breathers, so they will flare their nostrils so that they can take a bigger breath in. Retractions. So those are could be intracostal, subcostal, or they could be supraclavicular up in their neck. So babies are sucking in so hard to get oxygen that you actually can see them sucking their skin, like in between their ribs, under their rib cage, or even in their neck above their clavicles. Okay, so that's what retractions are. We might see some mild cyanosis, and babies can be tachypnic, so they're breathing fast, so they're breathing more than 60 breaths a minute. Sometimes these babies are breathing upwards to 80 or 90 breaths a minute to get in enough oxygen. Okay, and then so we just provide them with extra oxygen, whether that be a nasal cannula or whether that be an oxy hood over their an oxy hood over their head. So basically it's a clear little box, plastic box that oxygen is piped into. So usually, babies can transition out of this transient tachypnea of the newborn within a couple of hours, or it may take 12 hours. But anyways, here's your risk factors: maternal diabetes, asthma, male sex, so macrosomia, but the big one is C-section delivery. Okay, we can take an X-ray and diagnose this. So we'll be providing supplemental oxygen. We may even be providing IV fluids because if baby's breathing really fast, they don't need full bellies full of food, so we might not be feeding them. So we might be just hydrating them with fluid, or maybe even giving them a D5 solution to keep their blood sugars up if it's appearing that this is taking a long time. Okay. Now, meconium aspiration syndrome, pretty similar to respiratory distress syndrome in that So the babies will aspirate meconium. So they had meconium stained fluid. They were born. They had meconium in their airway, and then they took a big breath and sucked that down into their lungs. So that's bad. And then in addition to that, meconium deactivates surfactant. So now we've got kind of a double issue problem. We've got a baby with a meconium in their lungs, so they're not able to, it's a barrier to oxygenating, and then that meconium is also deactivating their surfactant. So these babies are super sick and can be super sick for a long time, because you can imagine how hard it would be to absorb and get rid of meconium. Okay, so it's a mechanical obstruction, it's a chemical pneumonitis, and it deactivates surfactant. So big problems for these kiddos. So signs of respiratory distress, or signs of meconium aspiration. So babies are cyanotic, they're apneic, they're respiratory distress, they're barrel-shaped chest because they're trying to open up that lung somehow and get oxygen in. And their skin, their nails, the umbilical cord, depending on how long they've been bathing in meconium, can be stained. It can be stained a green color, sorry. So we'll do tracheal suctioning. We'll start a UVC line and a UAC line. They're getting high levels of oxygen. They're getting, we're giving them surfactant. They're on antibiotics, and they are going to be a long-term patient. Okay, sorry. All right. So metabolic abnormalities, cold stress, hypoglycemia. We've talked about cold stress. When we have a baby who's cold, we're going to increase their respirations. They're going to start using non-thermal or non-shivering thermogenesis, which is not going to be enough to warm them up. They're going to start getting hypoxic. They're going to get hypoglycemic, and they're going to start having CNS problems. Okay, so we want, they're going to have increased oxygen requirements. They're going to have increased glucose utilization because they're going to be using glucose to try to fuel their metabolism. They're going to start getting acidotic, and surfactant production is going to start decreasing, so now they're going to start having respiratory issues. Okay, so here's just a schematic of how cold stress is going to start affecting all their systems. Okay, so you can run through this. So, so you can. The bottom line is our babies are that are suffering from cold stress are going to start getting hypoxic. They're going to start getting hypoglycemic. They're going to start getting acidotic. They're going to start vasoconstricting in their pulmonary system, which is going to probably shunt them back to fetal circulation. And they're going to develop hypobilirubinemia. So you can just kind of look at how that all just kind of the domino effect of being cold. So what do we do? Of course, we try to prevent heat loss. But if we already have a baby who's suffered from heat loss, then we're going to figure out some way to get them warm. So one of the ways that we get babies warm is we put them skin to skin with mom. However, if the hold on a minute, let me pause, please. We'll put these babies skin to skin. However, if we have a baby that's severely compromised because of cold stress, then they're probably going to go under a radiant warmer on the servo setting. So that's where the warmer detects the baby's temperature and keeps the heat output to keep the baby's temperature normal. If we have a baby that's severely cold, we can't just heat them up really fast. That's going to cause a problem as well. So we warm the babies slowly, and we could even provide warm IV fluids, and then we will be treating the hypoglycemia if that becomes an issue. So, hypoglycemia, how do we treat, or what is hypoglycemia? So, they are plasma glucose levels, or when we do a heel stick, it's less than 40. So, some facilities, there's some new research coming out about really how low can we go. And so I've seen some research that's talking about 30 to 35. But right now, currently, 40 is your number. So low glucose is below 40. Here are your risk factors, and you guys are very much aware of those. We've covered them several times. Here is your symptoms with the baby who has hypoglycemia. So they can either be lethargic or they can be irritable. They will definitely have poor feedings, poor suck, swallow. They might be cyanotic or pale. They will be hypothermic because low blood sugar. They don't have enough glucose to fuel their metabolism to keep them warm. They will start having respiratory distress, as we've seen before. They could even have tremors and seizure activity, and then they would have a noticeably high-pitched scream, or cry. So we do routinely screen all babies at risk, so your SGA, your LGA, your babies of diabetic mothers, and your preterm babies, IUGR babies, or any baby who has been resuscitated or has a hypothermia problem. Okay, those babies are going to fall in that routine screening, which is before every feed for 24 hours or 24 hours of normal glucose levels. So we want to feed frequently. So as I discussed in the earlier part of the lecture, like all the things we can do to help with feedings, but if we've done all those things and we are not successful and we need to start an IV on baby, we will use a 10% dextrose solution, okay? And at 80 milligrams per kilogram per 24 hours. That's how we'll calculate what our rate will be on our IV pump. Then if it's a very severe glucose problem, and even with 10% glucose or dextrose, we're not keeping babies' blood sugars normal, we can go up to 12.5% dextrose through a peripheral IV. But if we're even still having problems at 12.5%, keeping our baby's blood sugars normal, we can go up to 15%, but we have to use a UVC or an umbilical vein catheter, because 15% dextrose is too hard on the peripheral veins. Okay, and we absolutely never, even with the UVC, do we use anything above 15%. We'll never use D25, and we will never use D50. Okay, so when we are looking at getting the heel sticks for the blood sugars, there are two places that we can choose from. And from this picture, it does look like it's flat on the bottom of the baby's foot, but it's really not flat on the bottom of the baby's foot. It's really kind of on the corner of the side of the foot. Okay, so when we are in OB and we get our hands on a baby, we will look at the appropriate side, but it's kind of on the corner or the side in those two areas, on either side of the foot in these two areas. Okay. And it shows here, you can see the little, you can see the nurse has poked this baby. You can see the little poke mark on the baby's foot. So it's kind of like just right on the side or on the corner, that little fat pad, okay? So that's where you would put it. So we've talked about jaundice, okay? So we're not going to go in, we're not going to review these physiologic or pathologic jaundice now, but we're going to more so focus on jaundice that has made baby sick. So our levels are too high. Okay, so what we are worried about is bilirubin encephalopathy. Okay, so this is when the serum bilirubin levels are elevated to the point in which now it is affecting the central nervous system. So we'll see our babies who are lethargic, we will see our babies who are hypertonic, hypotonic, and with feeding difficulties. So I had said this morning that we will educate moms about signs and symptoms of elevated bilirubin, and I said these babies are sleepy, they don't want to eat, their bilirubin, so they don't want to eat, so they don't hydrate, so they don't have stools, so that makes their bilirubin higher, so they get sleepier and sleepier. Okay, so lethargic here is really talking about these babies that are absolutely, like, they're pretty much out, like there's nothing you can do to get these babies to respond or wake up. Okay, they're flaccid, they're just laying there limp, and they're not eating at all. Okay, and when the levels are so high that it's now affecting their brain, we really need to consider an exchange transfusion. In other words, putting them under the Billy lights at this point is not going to cut it. It's not going to be strong enough therapy to get this bilirubin down without causing permanent damage. Okay, so we may do an exchange transfusion, and baby will be admitted into the NICU. So if we're just doing Billy lights, baby can still be a patient on the postpartum unit. However, if we're needing to do an exchange transfusion, or if baby is on IV hydration or IV feedings, those babies are in the NICU. Okay, so if baby is not treated, the condition of kernicterus develops. Kernicterus is basically an irreversible damage to the baby. So they will have cerebral palsy, they will have mental retardation, they may even have hearing loss, delayed speech, all these problems, permanent brain damage and or death. Okay, so that has gone beyond the bilirubin encephalopathy, and now it has caused permanent damage, which is kernicterus. Okay. The treatment, of course, we're going to do transcutaneous bilirubin levels. That's where we use our little meter to measure the bilirubin level in the skin, transcutaneous. And then if those measurements are elevated, then we're going to do the serum bilirubin levels. If there's any anemia problems, we're going to maybe do transfusions. We removing maternal antibodies, so that would be through an exchange transfusion. And then of course, in addition, we will be doing Billy lights to help decrease the bilirubin levels. Okay. Phototherapy, feedings, IV fluids, exchange transfusions. Okay, so those are the big treatments. Now, so we're going to talk about RH incompatibility now. So RH incompatibility, this is how it develops. The mother is RH negative. The baby is RH positive. Mother's blood detects the RH positive baby because baby's blood cells are somehow mom gets some baby's blood cells, and then mom's body sees that RH positive, creates antibodies. Those antibodies then cross the placenta and then start attacking the RH positive blood cells. Okay, and then so that's just RH incompatibility in a nutshell. Now, the first pregnancy usually is not affected, and I said usually, and I'll explain why. So this exchange of baby cells to mother usually doesn't happen until delivery, or there was a trauma to mom's abdomen. We did an amniocentesis. Mom had an abruption. some sort of thing like that, then mother gets exposed to baby's blood cells. But typically this usually doesn't happen until delivery. So at delivery, then mom's body, or mom gets exposed to baby's blood cells, and then mom starts creating antibodies. That baby was born, so that baby doesn't have a problem. Now, if we don't do something about this, mom creating these antibodies, if we don't stop that process, then the next time she gets pregnant, if she gets pregnant with a baby who has Rh positive, then mom's antibodies is going to cross the placenta and affect the second, third, fourth, and fifth baby. Now, when I said the first pregnancy usually is not affected, the time when the first pregnancy is affected is if for some reason mom got a blood transfusion and got Rh positive blood for whatever reason, then she would create antibodies. If mom was pregnant and had a miscarriage, and we don't know what that baby was, that baby may have been Rh positive, then mom could be exposed to baby cells and create antibodies. So those are some of the circumstances in which the first baby could be affected. Okay, so what happens in Rh incompatibility when the baby's blood cells have been destroyed? So baby's blood cells are destroyed. So what happens with blood cell breakdown? Bilirubin's levels rise. Okay, that those raised bilirubin levels could cause neurologic involvement. So then we have our bilirubin encephalopathy. Okay, what happens is the baby starts producing erythroblasts, or tries really fast to produce more blood cells, but is going so fast that they're creating, instead of mature blood cells, immature red blood cells, which are not able to carry oxygen. So that causes erythroblastosis fetalis. So babies having oxygenation issues. This is with all this blood cell breakdown, we have a fetal anemia, a severe fetal anemia, then generalized edema all over the baby, and this is called hydrops fetalis. And then eventually baby has congestive heart failure and dies. Okay. Now, so what do we do? So one of the things that we can do is we can do an amniocentesis. So this is where we would look at the density of the amniotic fluid. If the amniotic fluid, or the optical density of the amniotic fluid, so if the optical density is increased, then that tells us that there is bilirubin in the amniotic fluid. Okay. With this test, the optical density, if it is low, then the fetus is either one, Rh negative, or the fetus is Rh positive with no or very little hemolysis. Okay. If the optical density is high, then that indicates that we do have fetal red blood cell hemolysis. Okay. We can do an ultrasound to evaluate for fetal anemia, and what we would see is edema. We would see ascites, so that's a bunch of fluid in the in the abdominal space. We would see an enlarged heart, and we would see hydramnios. Okay. We could also do a percutaneous umbilical blood sample. It's a quantitative measurement of fetal red blood cell destruction, and then if we have determined that this baby's at severe compromise with hemolysis, then we may do an intrauterine blood transfusion. So we do these at CMC. We have done several in the past few years with our perinatologist, and for this exact reason, for a severe fetal hemolysis going on because of an Rh incompatibility, maybe even just a fetal anemia. We did have one patient that was developing antibodies. It wasn't related to ABO. It wasn't related to RH. They could not determine why this woman was developing antibodies, but those antibodies were definitely crossing the placenta and attacking baby's blood cells. So we were doing serial intrauterine blood transfusions for this baby. Baby was delivered and did really well. Okay. Another treatment that we can do for baby in utero is a fetal abdominal transfusion, where we put erythrocytes in the abdominal cavity of the baby. Those erythrocytes are absorbed. So these are things that we would do for baby when we know that there's an RH incompatibility, that mom created antibodies, and those antibodies are now crossing the placenta and attacking baby. So these are things that we can do to help babies in utero, okay? Because if mom is already creating antibodies, we cannot do anything to stop that, okay? We want to stop her. We want to stop her from initially starting to create the antibodies. So we want to give her treatment before she creates the antibodies. If she's already starting to create antibodies, we can't do anything about it. Okay? So I may have said that a little bit confusingly. So anyway, so one of the tests that we can do on mom is called the indirect Coombs test. Now that tells us if there is RH positive antibodies in mom's blood, okay? So we would do this test to see if mom has been sensitized. If there are RH positive antibodies in mom's blood, then the test is positive, the indirect Coombs test is positive, she is sensitized, okay? So we can do titers frequently during her pregnancy, to see how much antibodies she's creating. If the titers start to get really high, then we can assume that those antibodies are crossing the placenta and attacking fetal blood cells. So then we would either just try to manage the pregnancy, watch baby, see if baby is doing fine, if baby is growing fine, if baby is showing any signs of anemia. We will then intervene with one of these treatments, okay? Now, so when mom first comes in for her prenatal visit, we will do her ABO, RH, and then if she is RH negative, then we will do this indirect Coombs to see if there are any antibodies, RH positive antibodies. Now early in pregnancy, now keep in mind, we don't know what baby is. We don't know if baby's RH negative or RH positive. So we're going to test to see if mom is creating antibodies in her early prenatal visits. And if she is creating antibodies, then we will need to assume that baby is RH negative and those antibodies may be crossing into the placenta, okay? So then we will keep an eye on baby. But early in pregnancy, if we do an ABO RH and mom is RH negative and her indirect Coombs test is negative, then we can assume that she has not been sensitized, okay? Then again at 28 weeks for the RH negative mom, we will do the indirect Coombs test. If the indirect Coombs test is negative, that means she is not sensitized, that means she has not developed antibodies, then we will give her RhoGAM, okay? But if we, at 28 weeks, if we do the indirect Coombs test and the test is positive, then that means she is sensitized, that means she is developing antibodies, okay? And we can't give RhoGAM at that point. It's not going to do anything. She's already created the antibodies. It's too late, okay? So then we will start watching the baby, okay? We will do our fetal surveillance tests, and if baby starts showing signs of compromise, then we might intervene, as I had showed in the previous slide, okay? Now, So we've done that at 28 weeks. Mom, we're going to say that mom was not sensitized, so the indirect Coombs test was negative. We gave her RhoGAM. Then, when this Rh negative mom comes in and has her baby, then we are going to test baby's blood. If baby's blood is Rh positive, then we will do the RhoGAM on mother. Okay. If an Rh negative mom comes to delivery, has her baby, and we test her baby's Rh, and her baby is also Rh negative, then we don't need to worry about anything. Okay. But we will give the RhoGAM if baby ends up being Rh positive. So what RhoGAM does is if there's any possibility that there are any fetal cells in maternal blood, the RhoGAM will coat those fetal cells and destroy them. Therefore, mom's body will not create antibodies. Okay, we must give the RhoGAM within 72 hours. If we don't give the RhoGAM within 72 hours, we're probably going to be too late. Mom's probably going to start developing antibodies. Okay. But if the Rh negative mom comes in, she gives birth, and she gives birth to an Rh positive baby, and we do the indirect Coombs on mom, and that test comes back positive, then that means she is sensitized. That means she has already created antibodies, and we do not give the RhoGAM. Okay? And then so what do we do? Well, now we test the baby's blood, and instead of doing an indirect Coombs, which we've done on mom, we will do a direct Coombs test on baby. And what that will tell us is if there's any antibodies that are connected to baby's Rh positive cells. Okay? If there are maternal antibodies attached to baby's Rh positive cells, then the direct Coombs test is positive. And then, therefore, that means that those antibodies are going to start killing baby's cells, so we will have to manage baby. Okay, manage baby's symptoms. Okay, so baby will get baby will become jaundice, elevated bilirubin levels, baby will start being anemic, so we will possibly need to be doing blood transfusions on baby. Okay. So the next time I see you guys, if you're confused about RH, if you're confused about sensitization, if you're confused about anything about RH and mom and babe and the tests that we do and the treatments that we do, please let's review this at next lecture. Okay, so make sure you ask me at next lecture. Okay. This is actually, it's kind of confusing at first when you start learning this, but once you can grasp this concept, then it's I think you guys will find this to be very easy to understand, but it might take a little bit of explaining to kind of grasp this concept. Now, ABO compatibility. ABO incompatibility happens when mother is type O and baby is either A or B or AB. Okay. It results if there is an ABO incompatibility, babies might get a little jaundice. However, the hemolytic reactions, like there are in RH incompatibility, are not severe at all. They're almost negligible, and we don't really do anything about this. It usually resolves. As a matter of fact, some hospitals don't even test for ABO incompatibility. That's how minuscule this can be. So a lot of babies will have ABO incompatibility. They'll get a little bit jaundice. They'll breastfeed. They'll bottle feed. And this will eventually resolve, and everybody will be hunky-dory. We don't ever even test for this sometimes, okay? And if we do test for it, like St. Pat's does test for it, Community does not test for it, St. Pat's tests for it. If they see an incompatibility, what do? They just watch the baby and make sure everything's okay. That's it. And usually everything's okay. So ABO incompatibility is not a huge, hairy deal. Okay? Okay, now, so we'll talk about anemia in babies. So remember I said I want you to know what your H&H values, normal values are for baby. And this is something that we don't even check either. So some facilities will always check an H&H on baby like at 4 hours of age, but most hospitals don't at all. The only time that we do our assessments for anemia. The nurse does her assessments for anemia. And if she feels like from her assessments that baby might have a low H&H or a low hemoglobin, she'll report that to the physician and tell them that maybe we should do an H&H on baby. But otherwise, we don't usually test routinely for babies' blood levels. But anyways, this is your normal value for hemoglobin, and anemia can be due is due to a blood loss, either during labor, during the prenatal period, during labor, or even after birth. How does baby have blood loss after birth? Well, the biggest the biggest reason is something happened to the cord, something happened to the clamp. Babies who are in the NICU and maybe have a UVC can actually probably bleed from that umbilical vein if people aren't watching that. There's some terrible horror stories about babies having a UVC, and the babies being covered up with a blanket, and the nurse not noticing that the baby is bleeding out from their umbilical cord. Okay, so anyways, blood loss after birth is possible. However, it's pretty rare. The blood loss for babies is usually in the prenatal period or during labor. Hemolysis, we've talked extensively about hemolysis. Baby's red blood cell breakdown, usually from Rh incompatibility, or they have some sort of red blood cell production problem. Okay? Physiologic anemia. Hemoglobin levels drop in the first 8 weeks of life. If hemoglobin levels drop below 10 to 11 in the term baby, or 7 to 9 in the preterm baby, then that's diagnostic for physiologic anemia. And then the bone marrow begins to start ramping up the blood cell production, and then the anemia disappears. So this is kind of like a normal process. Okay, usually doesn't need to be treated. Babies usually bounce back from this and catch up, and then all is well. Okay. So what is our nursing care? So of course we're going to do a lab test to check babies' H&H values. Our assessment parameters for a newborn with anemia is these babies are very pale. So we would, if we felt like that, if we felt like our baby wasn't breathing well, so if we had an anemic baby, we probably have a respiratory issue accompanying that as baby tries to get in more oxygen. So that would be our problem as well. So those are our assessment parameters. We would call the physician. We would say we need to do an H&H lab draw. Okay. So to treat anemia, we might provide iron supplements. We would figure out why the baby is anemic and treat that cause. However, if the anemia was severe enough, we would need to give blood transfusion, just like for any even adult patient. Okay, so then in addition, we would also be treating our respiratory problem as well to help baby with their breathing. Okay. So infection, signs of infection for baby or sepsis is respiratory distress. You can see all these signs and symptoms. If babies get an infection, it can happen really fast and they can start deteriorating very quickly, okay? So you can see all these signs and symptoms, but the last one here, tachycardia followed by apnea or bradycardia. So these can start happening very fast. This can spiral out of control. So we need to be assessing our baby very vigilantly, okay? So what do we do for a baby who's septic? Of course, we're going to control the baby's environment. So we may have this baby in a protective isolation to prevent any spread of infection. We'll definitely have them on an antibiotic, physiological support, so feeding, positioning, all those kind of things. And then we got to address the parents as well. We need to address the parents in any type of situation for baby, okay? Involve the parents as much as we can. Make sure our parents know exactly what's going on, and keep them as in close contact with this baby as possible. Okay, so other infections that baby could be getting. So if mom had a syphilis during pregnancy, baby is going to be exposed to syphilis, okay? So baby will demonstrate elevated IgM, serum IgM. Baby could have a rhinitis, can have fissures and sores on their mouths, a rash, and this copper-colored rash over their face and their hands and feet, okay? They can be irritable, they can have edema, hepatosplenomegaly, they can start having cataracts problems, they can be born SGA, and then once born they will have a failure to thrive. So what do we do? Well, standard precautions, of course. Babies will go on antibiotics, and then of course they can be cured from their syphilis, okay? But if the syphilis has caused any permanent damage, the damage may not be able to be cured, okay? Gonorrhea, here are your signs, here's your symptoms of your baby: conjunctivitis, pure discharge from their eyes, and then they can develop a systemic infection. So we give the ophthalmic antibiotic ointment in their eyes, and hopefully that will be all they need. Definitely need to follow up to make sure that it has been cleared up, and then if there was any permanent damage, of course, treatment and supportive care for the permanent damage, okay? We may not be able to, if it's permanent damage, we won't be able to cure that, okay, or fix that. So herpes simplex virus, so if mom has a herpes infection, it can be transferred to baby. Oh, by the way, if mom has active herpes lesions, she is not a candidate for vaginal delivery. A mom can have herpes but not have active lesions, and she will be permitted to deliver vaginally, okay? So baby can get these lesions. Baby could develop DIC, pneumonia, hepatitis, start developing neurological problems. This is not something that can be cured in babies, so we will need to do our precautions. Put the baby on a cyclovir to control the symptoms, and then referral for continued management of this child with positive herpes. Cytomegalovirus virus, very similar to your herpes virus. Here's your symptoms for your baby. It cannot be cured as well. We can get these cultures to test baby for CMV. One of the problems with CMV is their mom can have CMV and display no signs and symptoms, therefore she's not tested and we have no idea. Okay? So some OB doctors will test for CMV, some don't. If she has herpes, well, they'll probably test for CMV, but probably no difference in the care there. Mom having a chlamydia infection, so hopefully we catch this and treat mom, but if we don't, then these are the problems that could happen with baby. So we will administer the ophthalmic antibiotic ointment and follow up with the pediatrician for making sure baby has been cleared of this infection. Okay, the chlamydia can be cleared, but if it caused any permanent damage, that may not be able to be changed. Okay, so these last slides do talk about all these infections. So you can, this is might be an easier way for you to study. I don't know which you would prefer to use, so I went ahead and put it on here. The one thing I did not have a slide on is Group B Streptococcus, or Group B Strep, or GBS. Okay, so we test moms for GBS usually around 36 to 37 weeks. It is a vaginal rectal swab. We send that in for culture. If mom is positive, then we make note of that so that when she comes into labor, we will put her on IV antibiotics during her labor. We're not putting her antibiotics to cure her of group beta strep. We are putting her on antibiotics to prophylactically treat the baby so the baby does not become infected. Okay. If this woman comes in and has a C-section birth, she does not need to be treated. It's when the baby comes through the birth canal that the baby would be exposed to the GBS, so it's a vaginal delivery. But anyways, if babies get sick with GBS, they can get sick very fast, so they will need to be admitted to NICU and put on antibiotics. The other thing I'm going to say about GBS status is if we have a woman come in that with unknown GBS status, or if we know she's GBS positive and she's come in and precipitous delivered and we did not get antibiotics in her, then baby will be on close observation and will not be discharged, usually will not be discharged from the hospital until after 48 hours. So within 48 hours, if baby was exposed to GBS, we anticipate we would be able to detect that within 48 hours. So after 48 hours, if baby shows no signs of infection, then we feel safe and that baby is out of the woods. Okay. So GBS is a real bad thing for babies, so we watch them pretty close. Yeah, I forgot to delete this. Anyways, this section in your book, do not forget about this section in the book, but I didn't feel I needed to lecture on that. So if you have any questions, please let me know during our next lecture.